With that, I'm going to turn it over to Dave.
Yeah, very good there. Oh, they've given me 59 minutes. I had 4 for the last talk I had to give at the MBS meetings, where the moderator asked me to do a blitz. Y'all ready? No. I'll slow down a little bit here. We're introduce Kim Lynn and Shannon McCormick here to talk about frequently asked questions, and I get to start out with a little bit of a review of FA for those who need a review, as well as for the new people in the audience. So we're going to talk about all this through frequently asked questions that we have in our clinical practices. We're going to start out with an overview of FA for the new people and first timers, as well as those people who'd like a review. You're welcome to ask questions on it at the end as well, just to see if there's anything new that you want us to talk about. Then we'll talk a little about some neurological features, followed by some cardiac features of the disease, and then questions on diabetes and metabolism, and then one slide at the end on a topic we'll have to review again every year for a while. So what is FA? Friedreich ataxia is a rare genetic disease, a neuromuscular disorder. It affects about 1 in 50,000 people in the United States, plus or minus a little. We're not going to argue about the exact number. About 1 in every 50,000 people. So it's about 5,000 people in the United States, maybe a little more, maybe a little less. Almost everyone has the same combination of mutations. 2 GAA expansions in the FXN or frataxin gene, which lead to inability to make large quantities of the protein frataxin. What this frataxin does is it's involved in mitochondrial function, and its absence thus causes mitochondrial dysfunction. So it's that idea was come up with, originally people came up with it in 1997. It's now 27 years later, and that same basic idea is there. It's just been refined through the years. Silencing the frataxin gene gives rise to mitochondrial dysfunction, which gives rise to the disease. No more, no less. FA is relentlessly progressive, most commonly diagnosed between ages 7 and 15. But those individuals require mobility aids by their teens or 20s. The life expectancy can be into early adulthood for those who present, particularly in the first decade of life. Though shortening of life is less common the older you get at age of presentation. As I mentioned, it's caused by a very uniform genetic mutation in 95% of individuals. Let's see if I can get this pointer to work. I have to go to the screen. So in an quote, normal individual, we'll put that in quotes right now. This is the frataxin gene. There's a short expansion of GA repeats in the first intron, the sequence between the areas that are made into protein, and you get normal levels of frataxin, this diagrammed protein here. In FA, what happens is this expands, so you don't entirely silence the gene, but you make far less, 10% or less of normal. In about 5% of people, and both 95% of people have 2 of these expanded GA repeats, most commonly between 600 and 900 repeats in the American population. And that gives rise to silencing of the gene. In about 5% of people, officially 4, you have 1 of these repeats, and then another single change, either in exon 1, 2, 3, or 4, or sometimes in the regions in between, which leads to a mutation where the frataxin, you may make it, but it doesn't function right. So everyone except 1 person in Turkey has at least 1 expansion. So you'll know from the genetic test, more or less, whether a person has FA. You can test both for the GA repeat, and then if you don't find 2 repeats, you can follow it up with sequencing to find the point mutation. So we can make a positive genetic diagnosis in essentially everyone. So this is that pathophysiology. The GA repeat expansion gives rise to a deficiency of the protein frataxin, which gives rise to impaired mitochondrial function, which comes in 2 ways. To some extent, you can get buildup of iron and reactive oxygen species, but perhaps more important is you simply don't make enough energy. You don't make enough ATP. And as a result of that, you have this unhappy cell, crying cell, which is short of energy. I do not understand why it's wearing these shoes. I didn't draw this diagram, and why this cell has arms. I really am just sort of confused here. But this low cellular energy gives rise to the symptoms of FA, and you can see at this point we do some hand waving. those being in the retina, the cerebellum, skeletal muscle, pancreas, peripheral nerves, and the heart. So that's all there is, the pathophysiology of FA at a superficial glance. And that's all we need to know to understand roughly how treatments come about. So FA is not just a neurologic disorder, it is multidisciplinary and requires multidisciplinary care. That's why you have two more people up on the stage today. The 8 features clinically: ataxia, loss of balance, fatigue, impaired speech, vision, and hearing, which are clearly very important things to act upon. Scoliosis, curvature of the spine, which sort of runs idiosyncratically from the other features. Heart disease, not classical heart disease, not classical atherosclerosis, but different forms of heart disease, as well as diabetes, which Shane will tell you more about. One thing we should remember is it's affecting all these organs, but I didn't tell you when they start. This is just an example. This is a normal spinal cord, obviously taking an autopsy. This is, and purple out here is good. It means you have all your long axons and all your long fibers in the spinal cord there. This is the spinal cord of a 4-year-old who died asymptomatically from FA. He died from something else. And what you see is it's not nearly as purple as this one here. It's actually quite pale in the back, which tells you that 4-year-old who had no symptoms already had many features of the disease, perhaps 5 years before we were destined to meet that individual. So a lot of it happens before we ever meet people. And that takes us, is one of the things which has revised our thinking to some degree. So now we're going to talk about some questions, real questions which come up when people come into the office. So I get to go first since I'm here. That's efficient. What do my repeat links tell me about how Friedreich ataxia will affect me? I will say that is probably the most common question. So the length of the shorter of those 2 GA repeats predicts the severity of disease. Severity is measured by age of onset, as measured by speed of progression, as measured by the amount of frataxin protein you make when we go and take it out of cheek swabs or out of blood or out of muscle or about any, even the heart probably, though we haven't done that. But actually, age of onset is a better predictor of how you're going to do. That's a little surprising, you think, but in fact, age of onset is a more reproducible assay than the frataxin assays or the GA repeat assays. So you know how you're going to progress when we figure out when you come to see us for the first time. That is as good a predictor as anything we do biochemically. Now, it's not a perfect predictor, but it's just as good as the biochemical test. So knowing the number of GA repeats can be helpful. It reinforces. It means you have 2 ideas on whether this is going to be faster progressing or slower progressing, but you don't have to know it to actually manage it. I'd always prefer to know it, but I know some of our good friends in genetic testing companies, that would be a euphemism, of course, do not provide that because the assay is in fact quite hard to do. And now next year, we'll probably introduce on how some of the testing gets a little confused sometimes. So you don't really have to know it to manage someone. People who have point mutations or deletions can progress faster than expected or slower than expected, or in some scenarios, simply not even look like they have Friedreich ataxia. So all bets are off with people with point mutations or large deletions. Are there any other genetic modifiers of Friedreich ataxia? You will read about other genes where other diseases where they find a new modifier which genetically makes the first gene be better or worse. That's easy to answer. No, not really. There is one small one we stumbled upon that changes things a little bit, but we, 15 years after the initial time we looked for it, we still can explain what it does. So really, we have found no modifiers, and we've actually looked reasonably hard. So if there are a lot of genetic modifiers, there are probably lots of modifiers that have small effects on their own. So it's going to be continually hard to find these. GA repeat and age of onset are predictive, but they're not perfect. The best predictor of how you will change is how you have changed. Duh. But that's actually true. The people who change fast usually continue to change fast, and those who change slow continue to change slow. The other thing to always wonder about is if you see a change in your progression. You know, not everything in life and not everything in medicine is Friedreich ataxia. You are allowed to get second diseases, and second diseases obviously will change things. And no, to my knowledge, Friedreich ataxia does not protect you from those other diseases. So if you see something new which makes no sense, you may have a second disease that someone should look for. So don't forget about those modifiers. How is iron related to Friedreich ataxia, and should I be taking iron supplements? Yes, I remember that first study, Jen, when you had to get those blood samples. I remember we moved on to other studies after that, which made you go to FARA, if I remember correctly. Ask Jen about those studies later. So we don't talk as much about iron as we used to. The idea that this is iron overload is simply not true. FA is not a disease of iron overload. Think about it more as iron maldistribution, where there's more iron in the mitochondria, and even whether that mitochondria iron is something primary or secondary is unclear. But the rest of the body actually acts as if one is iron deficient. So it's not iron overload, and simply sucking the iron out by chelation will not do it will not be beneficial to a major degree. In fact, FA patients are commonly mildly anemic. Not enough to really have symptoms, just mildly anemic. And if you look at the indices of amount of iron in the body, almost everyone with FA is mildly iron deficient. Their ferritins are low, as are their total body irons. So on occasion, you will need to treat that iron deficiency because it will give rise to a significant anemia. If the hemoglobin level gets below about 11 and the person has symptoms, you could treat it. But a lot of that time, the fatigue is not necessarily from the anemia, it's from FA, and they're not necessarily connected. You can take oral iron supplementation. This is probably the most common question I get now. Oral iron supplementation is fine to bring it up, but it may not be necessary. I would discourage people from getting IV iron, which restores your iron levels very fast. But we have had some people tell us that their hearts have worsened when they got it. Is there any true evidence behind that? No. But there are some people who have reported, and there's no need to raise iron levels fast, so why not just take the slow oral approach, has been done for generations of physicians. Remember also that if your hemoglobin is very low, less than 10, it's not from FA, it's from something else, usually gastritis, ulcers, something in the gastrointestinal tract. So don't think that, again, that everything is related to FA. Let's move on to the nervous system. How does FA progress neurologically? When will you lose the ability to walk, if that is within your destiny? Well, everyone varies a lot on this. And not everyone changes their walking abilities in the same way. You see here several different individuals who have, as they're having more difficulty, find different ways to compensate. Walking on walls, using a rollator or a walker, and then eventually people will start to use wheelchairs if we find no intervention. The amount of time to a person loses the ability to ambulate is dependent on the disease severity and their age of onset. This is from a paper that Christian Rummy did with us several years ago. This is the duration of disease before a person lost the ability to walk. This first line is the people who presented before age 14. You see that it takes about 11 years before they lose the ability to walk. The second line is the individuals who present between 15 and 24. You see that number is about 18 years. And then you look at the individuals who present after age 25, and that number is about 24 years on average. So age of onset, which is a surrogate for GA repeat length, does predict how long things will change. How long before is a person needs to use assistance. But remember, not everyone is the same. The best predictor of how you will do is how you have done. And not everyone will go through the same set of devices. It's a matter of what works for you. FA is not just a disease of balance. There are other neurological symptoms as well. In particular, spasticity, which is a form of increased muscle tone associated with weakness of the legs, where one's legs get stiff, but also hard to move. And then variety of forms of pain in Friedreich ataxia, which aren't really talked about much. Why do these occur? Well, because FA is not just a disease of the balance pathways. In fact, if I met the people who are at mid-stage of disease or later, I wouldn't have called this disease Friedreich ataxia. I'd call it Friedreich spasticity, because that becomes the dominating feature as things go along. The good news is we can actually treat stiffness or spasticity. We can lower the amount of muscle tone with medicines, baclofen or tizanidine. They have the side effects of sleepiness. Their other side effects are sleepiness and sleepiness, but you can manage through it to find the right amount for you. They're not perfect drugs, but they do work. The other neurological symptom that comes up is neuropathic pain or other forms of pain. Pain happens. Don't be ashamed to tell your doctor about it. Lots of different causes, but the one we talk about most is with the nerves, peripheral nerves dying. You can still feel things in your feet, but you actually just feel like it burns all the time. That can be suppressed with a variety of drugs. The most commonly used is gabapentin. The second one is Lyrica. Their side effects are sleepiness, and sleepiness. So you just have to work with your physician to find the ideal amount. But do not forget that these symptoms can be treated. Is depression a part of Friedreich ataxia? I think there's an easy way to approach that one is depression can be a part of FA because depression is a part of everything and every disease. It's part of FA. It's common in all central nervous system diseases. At any given moment, the incidence of depression in Parkinson's disease is 40%. Think about that. About 1 in 2 individuals with Parkinson's disease is depressed at any given moment. 5% of all the people without FA, as well as 5% of people in this room, will have a major depressive illness in their lifetime requiring medical treatment. That's a real number. That's common. Depression to a physician, though, is more than just feeling sad. It's excessive fatigue where you just don't do anything when you have the motor ability to do so. It's associated with altered sleep, particularly difficulty waking up early and not being able to fall back asleep, classically, although other sleep patterns are also involved. A lack of interest in anything. The question we always ask is, if you had your favorite meal in front of you, would you want to eat it? And if the answer is no, that person is clinically depressed. And then finally, feelings of hopelessness or self-destruction. If you have these or someone has these are the criteria for medical intervention expeditiously. Remember that antidepressants are safe in Friedreich ataxia and they work. This is something to talk to your doctor about now. And it is treatable. And one of the things about depression is it is time limited in most individuals, so it will reverse over time. So treatment with antidepressants is not a lifetime event. So on that note, I get to turn it over to Kim to talk about the heart. I'll be back.
Good morning, everyone. Thanks, Dave. All right. So this may be a bit of a review for many of you, but I'm back to talk about the heart and FA. And of course, the first question is, well, what are the heart abnormalities that are seen in FA? So heart involvement of any sort eventually shows up in most people with FA. The most common thing that we see is called a hypertrophied or hypertrophic cardiomyopathy. The pattern can be concentric, where the thickening of the wall of the heart is all the way around, or it can be asymmetric, meaning one wall may be more affected than the other. And when I'm talking about the walls of the heart, I'm talking about the bottom chamber, the ventricles that do the squeezing. This can progress to a dilated cardiomyopathy, where the heart is actually more enlarged and may not squeeze as well at that stage. And then abnormal heart rhythms or arrhythmias have also been observed. In FA, this is especially prevalent in terms of abnormal rhythms that start from the top chamber of the heart, so atrial arrhythmias. Commonly, when we do those Holter monitors to check a person's heart rhythms, we may see just single extra beats coming from the top chamber of the heart. And then we know as folks get older, they may develop atrial fibrillation, where the atria are going at a rate that's discordant from the bottom chambers of the heart, or atrial flutter. This is a new question for this year, but one that's really near and dear to many of our hearts, is whether it's okay to exercise. And is it okay if I exercise even if I have heart involvement or cardiac disease in FA? Does anyone know the answer? Yay, yes. Good, so you've asked the question and heard the answer. So exercise is good for most hearts. And just having a diagnosis of Friedreich ataxia does not mean that exercise is contraindicated. If some of you have heard that before, that may be a remnant of an older adage that folks with hypertrophic cardiomyopathy shouldn't exercise. That was common in my field even as of 3-4 years ago, and still persists to this day, that many folks who have a thickened heart muscle for any reason, usually not associated with FA, are told not to exercise out of a concern that they do have a higher risk of abnormal heart rhythms. But there's a lot more research that has come around that helps us to know that exercise in and of itself is not necessarily the provoker of abnormal heart rhythms, especially in folks with FA who more commonly have atrial arrhythmias and not ventricular or bottom chamber arrhythmias. Now, this is a overall, answer. It's not a person-specific answer. So you may have something specific about your heart for which your doctor may be specifically concerned. But just having the diagnosis of FA doesn't mean exercise is off the table. So in unusual circumstances, your doctor may recommend some limitations to your activity, or they may send you through certain testing to see what increasing your heart rate and what pushing your heart does to your heart rhythms and how your body handles that. If the doctor doesn't know how to test that in you because you have different physical abilities, know that there are different types of adaptive exercise equipment or ways to test people's heart rhythms that we didn't have before. Even the old Holter monitor that some of you may have worn in the past and had to cart around a big pack with wires sticking off of stickers, that's gotten better. The Holter monitors are smaller and more portable. So there are ways to look at your heart rhythms and better assess your abnormal rhythm risk. Some pointers for everyone. In fact, everyone in this room, even if you don't have FA, please ensure that you're well hydrated before, during, and after exercise. This is particularly important though for folks with FA because again, if you have a thickened heart, your heart muscle may be more stiff and you may be more prone to not tolerating shifts in your fluid status or having your tank be more empty. And so making sure you go into exercise or stressors with a full tank, making sure you're well hydrated is really important. On the other hand too, people in general often have fainting episodes. But if you have FA and if you have a thick heart and you faint, your doctor's going to be really, really, really concerned because they want to make sure they didn't miss something and they'd be more prone to restricting you from exercise. So try to prevent that. Make sure you're hydrated. Okay. And then also just get creative about safe ways to move. I know a lot of folks were out yesterday for the ride and you've seen all kinds of different types of bikes and trikes. That's not the only way to be active. There have been folks that we work with in New York who've actually come up with exercise regimens for folks at home who have limited mobility. Even just doing arm exercises if leg exercises aren't possible. I know there's a session later today, a breakout in which one of the topics is, activities and hobbies, some of which are physical. Please, please, please get creative about your movement and staying active. Okay, this is another common. What does it mean if I have FA and I get chest pain? So the bottom line for this is I just want to make sure folks know that chest pain is not automatically the equivalent of having a heart attack. It's the first thing that a doctor's mind goes to, especially if you're showing up in an ER with chest pain. And it may be the first thing that comes to your mind also. It may give you a lot of worry and consternation. Now, it is, of course, possible that anyone with chest pain could be having a heart attack. What's complicated in FA is that one of the tests that we run to evaluate with whether somebody's having a heart attack is to get a blood test called a troponin. And that may be elevated at baseline in many folks who have FA already. So I'll talk about this a little bit later, but knowing your baseline is very important. And then really getting the whole story because chest pain is really common. Okay. And it's a common symptom in young people. FA is no exception for that. And by far the most common cause for chest pain in a young person or a person with FA is anxiety or muscle spasm over any sort of coronary or macrovascular heart problem. It's really, really rare to have a clinically significant change in coronary perfusion that's causing the chest pain. So I hope that's of some reassurance to you guys. FA heart is known to have microvascular disease. So the smaller blood vessels may have a harder time getting the oxygen they want when the heart is under stress. And so it is possible that during stressful events, some of that chest pain may be related to decreased coronary perfusion, but not of the type that needs to send you to the ER, to the cath lab to have your coronaries shot and have a stent placed. Okay, so again, chest pain in FA is not necessarily equivalent to a heart attack. I've had many people go through that, and it's not a fun adventure. So macrovascular disease, meaning typical coronary artery disease, is not commonly seen in Friedreich's, although, of course, if you have a family history of coronary artery disease and high cholesterol, history of diabetes, those risk factors may apply. And like Dave said earlier, people with FA can have other diseases, can have typical heart disease as well. Okay, so a corollary to that is, what should I tell my doctors about my heart if I'm coming to the ER? And the bottom line here is really just knowing what your own baseline is and being your own best advocate, or having the person with you understand and know what your baseline is. So, as you're going through this journey, regular surveillance with a cardiologist is important. Ask your cardiologist for baseline studies so that we know and you can describe to other doctors what your heart is like at a point in time where you're feeling well and not having chest pain. So a copy of your EKG, because your EKG is probably most likely not going to be normal at baseline. But if you come into the ER with an abnormal EKG at the time you're having a problem, they might think that's a new finding. So get a copy of your EKG at baseline. You can even take a picture of it in the clinic or ask for a physical copy, but know what your tracing looks like and actually have it to give it to them or show it to them on your phone. Also helpful is your most recent cardiac troponin level, again, because for many folks with FA, that number may not be normal at baseline. If you have an abnormal troponin in the ER, again, the ER doctor may not be familiar with that, and they may wonder, oh, is that a change from baseline? Is this a new finding, and does it mean I have to send this person to the cath lab? So if you show up in an ER with chest pain or abnormal rhythm, the doctor can then see, if you can show them, whether an elevated troponin or an abnormal EKG is different than your own baseline. Okay, and then finally, on a more elective basis, how should the FA heart be managed if you have to go to surgery? So we've had an increased recognition of the higher risk nature of surgery, in particular spinal fusion surgery in people who have Friedreich ataxia. And we think this is because blood loss and fluid shifts are less well tolerated, especially because the stiffer, the thicker heart in FA doesn't like not having enough preload, meaning return of blood volume to the ventricle. And then low blood pressures, low blood sugars, and stress, which all can happen in a long, complicated surgery, may contribute to metabolic decompensation or derangements in the operating room. So the risks for folks going into a prolonged or difficult surgery include congestive heart failure and heart rhythms from a heart standpoint. However, on the flip side of this, with close heart surveillance, these surgeries can go smoothly. It's not that you have to say, oh, this is a high-risk surgery, I should never go through it. With close, careful planning and making sure that the folks taking care of you are on board and ready to pay close attention to you with respect to your heart health, this can go well. So some of the things that we've done at the Children's Hospital of Philadelphia, where I work, is we've talked to the anesthesia team, the people who help you just be asleep and not remember your surgery, about whether this is going to be a prolonged enough surgery that we should think about having a special echocardiogram called a TEE, or a transesophageal echocardiogram, done during the surgery to be able to visualize the heart and the heart function and the heart fill throughout the procedure at any point in time where they're trying to figure out, is the low blood pressure because of blood loss? Is it because the heart's having a problem? Is it a combination of the two? And then also troponin monitoring may or may not be indicated, again, depending upon whether you have a normal or an abnormal baseline. And then we want that team who's watching you both before, during, and after the surgery to pay close attention to your heart rhythm. So that means having you on a telemetry monitored bed during that recovery, and then volume status. So making sure that your heart gets proper preload, and that may mean giving extra fluid during and after the surgery, and then watching to make sure that your body's handling that fluid, because at some point your body may tip to the point of needing help bringing extra fluid off. Okay, and with that, we're going to move on to FAQs for Dr. McCormick.
All right, thank you. I really appreciate the opportunity to come speak with you. I always learn a lot from this session every year. So the first question that we sometimes get, does Friedreich ataxia affect growth in puberty? And of course, particularly focused on children with childhood onset disease. And we actually have insights about this question because of participation in the natural history study. So Jen pointed out the many values of that participation, and this is one example. So this is a diagram of typical height velocity. You might be used to seeing children's heights plotted on the y-axis of the graph. This is how fast a child is growing. So you know that during puberty, children tend to grow more quickly. Growing more quickly requires a lot of energy. So what we found, perhaps not surprising, is compared to typical reference populations, children with Friedreich ataxia may not achieve the same growth velocity, may not grow as quickly during their pubertal growth spurt. So that was one insight we had from the paper. Also, some of the other points that you'll see on the right, children with Friedreich ataxia are more likely than the general population to have body mass index measurements that suggest underweight. So nutritional status is really important to revisit and talk about with primary care doctors, especially for some of our youngest patients. And children with Friedreich ataxia are also less likely to have excess weight compared to the general population. However, in contrast to the children, by the time individuals transition to adulthood, unfortunately, like many in the population, excess weight gain can be a challenge. And for people with Friedreich ataxia, that excess weight gain can have even more consequences than it may in the general population. One includes problems with mobility. So folks who have gained excess weight may have even more difficulty with transfers, with staying active. Also, we've shown that things like diabetes risk, macrovascular heart disease, that can also be affected by the pace of weight gain. So really important to pay as much or even more attention to the patterns of nutrition and weight gain, both in childhood and adulthood. We already talked about the pubertal growth spurt, and I'll mention that height in Friedreich ataxia seems to be another indicator of the genetic severity of disease. So children growing less well than you might expect based on their family, not surprisingly in pediatrics, reflects their overall health. A couple of points made in this paper that I would encourage you to take with you. One is there's a lot of missing measurements in people with Friedreich ataxia. And even in our own clinic at CHOP, where we take care of people with mobility impairment, sometimes we have to remind our MAs that just taking, the measurement from 6 months ago and carrying it forward is not appropriate to do, right? Just because it's difficult to weigh and measure the child doesn't mean it's actually not incredibly important to do. So it's important to do safely. If people can stand with support, then making a standing measurement makes sense. But we also have length boards. We have the ability to measure different parts of the body, like the tibia, like the leg bone, that gives an index of growth. So those missing measurements are not okay. We really need people and in the pediatrician's office to remind them that, hey, like this is something that we should do because, for example, weight loss, weight gain, those are important indicators of health that children with FA should have measured, not omitted because it's difficult. So that's one point. The second point from this manuscript refers to a point Dave made earlier about the possibility of second diseases. So we see people in our clinic with Friedreich ataxia who aren't growing well, and other people have attributed, say, well, you all have shown that Friedreich ataxia can affect growth, so that's got to be what this is, right? Well, what we say, even though it should be illegal to have a second health problem, it isn't, right? And what we really are focused on are treatable health problems. Common problems like thyroid disease, like celiac, those can exist in folks with Friedreich's just the way they do in the general population. And if you have someone attributing a child's growth pattern without having investigated to Friedreich's without doing due diligence, then you might miss the opportunity to have that child thrive in the way they could. So always get measured and don't automatically attribute whatever the pattern is to Friedreich's without considering other options. And then what makes sense to do to help overall health in the course of Friedreich's. So should bone health be screened in folks with Friedreich ataxia? We get this question often, and I think at a prior symposium we talked about a colleague who had a recent fracture. So many people will have heard, I will either have had fractures, broken bones themselves, or will have heard of folks who have. So we've found both in our deliberate research, in surveying patients, that having low bone density is really common in people with Friedreich ataxia. So the way we evaluate bone density is a DEXA scan, dual energy X-ray absorbed geometry. That's what that stands for. The way we measure it, it's really having someone lie on a table. So this is an example of a DEXA scan. You may have heard older relatives who get screened for osteoporosis with the DEXA scan. It's the same technique. It uses a very low amount of ionizing radiation. So it is X-rays, but it's the equivalent of a cross-country flight that many of you may have taken to come to the symposium. So it's a relatively low amount of X-rays, and it looks at how dense the bones are, how mineralized they are, how much calcium and phosphorus is in the bone. And the reason we care about bone density, about how mineralized the bones are, is because that is one factor that affects how strong the bones are. And bones that are stronger are less likely to break. But bone density is only one factor that affects the likelihood of fractures. One other risk factor for fractures is falls and how well people support themselves when they do fall. So fracturing and falling, really complicated, but worth considering what each individual's fracture risk could be based on their bone density and their other factors. So we've shown in our studies that adults with Friedreich ataxia have lower bone density at really important regions of the skeleton that fracture easily, including the femoral neck, which is in the hip. So hip fractures are really painful, and they can set people back mobility-wise. So preventing those is a really big deal. Vertebral fractures can cause a lot of back pain. The vertebrae can be crushed because they're not as strong. So those are things we've seen as well. Children with Friedreich ataxia also have lower than expected bone mineral density. One of the ways that bones get stronger is that they're loaded by contracting muscles. So walking and things like weight-bearing exercise help contract the muscles and strengthen the bones. And it's particularly important in childhood during the time when bone density is being accrued to have that happen. So if it doesn't, then that predisposes to lower bone density. The reason this is relevant, particularly in adults, but in children too, is that we do have medicines that are available that have been shown in adults, and we're gaining experience in children, have been shown to prevent fractures in the future, right? So since fractures can be painful and set people back health-wise, it's important to identify folks who might benefit from those medicines. So the question is, who should be screened, right? Like, everyone should be talking with their primary care doctor or their Friedreich's doctor about their risk factors for poor bone health and what common sense things they can do to optimize. Things like getting enough calcium and vitamin D, which we're going to talk about, getting weight-bearing exercise to the extent that's safe and appropriate, strengthening the muscles, and taking steps to avoid the kind of falls that can cause fractures. Like, all of those things are worth brainstorming about and discussing for everyone. And then for DEXA scan, who needs that scan? We say anyone should get a scan if it's going to affect our decisions with respect to treating them. for more specifically, am I going to choose a bone strengthening medicine? And people would say, well, why don't you just give that to everyone? It's because they have side effects, right? So we want to choose the people who are most appropriate for that. So we say first, anyone with a fragility fracture should have a DEXA scan. So if you do break a bone, a fragility fracture is a broken bone where we say, like, that's really surprising. Why, someone who fell from standing, or sometimes some of our patients come in with pain and a broken bone, and you say, well, what happened? How did you break your bone? I don't know. I have no idea. I just had that. So that meant in the course of their kind of routine activity, something happened and they broke a bone. So a fragility fracture is a broken bone where we wouldn't expect that degree of injury would produce that. So anyone there needs that. Typically, we think after 2 to 5 years of primarily using a wheelchair, folks in that range have had less muscle loading of the bone, and so may be more likely to have lower bone density and increased fall and fracture risk. So those are also folks. And then newer thinking, we say, well, gee, what if we, with the benefit of some of the natural history studies that Dave was showing us, what if we identified people who were maybe within a couple of years of losing ambulation? What if we focused on those individuals to make sure they don't fall and break a bone, because that might hasten their loss of ambulation, because an injury like that can be difficult to recover from. So worth talking about with your team. This is another question I get often. Should I be taking vitamin D? So I'm curious if people know, what do you think I'm going to say? Yes, right.
Because you're an American.
Yeah. So yes, or a multivitamin with vitamin D. So vitamin D deficiency is common in the general population, living at the latitude that we live. Our bodies get vitamin D, synthesize it from the sunshine only during a few months, and only if we're not wearing ton of sunscreen, which, if you look like me, is not a great idea, right? So the rest of the year, and for people who are wearing sunblock, getting vitamin D, enough of it, is really difficult, right? And vitamin D is important for absorbing calcium from our diet and putting it into the bones. So if you have vitamin D deficiency, the really important adverse consequence for the bone is that you don't absorb the calcium that you need so that you can put it into your bones. So there's a controversy in healthy individuals. Do we need to bother checking vitamin D levels, because we know deficiency is so common, even in people who eat healthful diets? This is the one micronutrient that I can think of that even people who are consuming a pretty rich and varied diet find it hard to get enough of. In healthy individuals, it's like, do we really even need to measure levels? And the answer is probably not for healthy folks, because I've listed our usual recommendations empirically up there. And people will, by the way, go back and forth and disagree, like 1,000, 2,000, like what's the optimal empiric, meaning like without a level, what's like reasonable. These are my, like, this is what I give my kids, for example, what I take, and my husband, what I take myself. So for kids under 10, 20 micrograms or 800 units of vitamin D3. For 10 years and older, 25 micrograms or 1,000 units of D3. And then anyone who really has risk factors for adverse bone health, I think a single vitamin D measurement is not unreasonable to ensure that they're getting to levels that are reasonable. We usually target 30 to 50 nanograms per ml. Calcium intake is also really important too. So when you look at the percent of calcium on a nutrition label, 100% of your daily intake is for adults. So kids need to get around 130% from their food in order to have enough calcium to load their bones. This is a time to make the point that there are different forms of vitamin D. Vitamin D3, cholecalciferol, is the one that we recommend for repletion. We do not recommend calcitriol activated vitamin D. Anyone who has questions about that, we can talk about it later, but D3, cholecalciferol, is the one. And many of your dietary supplements will have, or not many of them, but some of them will have a USP verification. So it's one way of knowing that it has in it what it's supposed to. So if you're choosing a supplement, I recommend you choose one that has a USP label. All right, so switching gears to diabetes a little bit, how should blood sugar be monitored in Friedreich? So it remains my goal that no one in the Friedreich's community has, once they know about their diagnosis, get very, very sick from diabetes, because everyone should be screened promptly and everyone should think early. If there's a change in their status that like they otherwise don't understand, the diabetes be on the list of things you think of to check for so that you can identify it and treat it before you get very, very sick. So we have treatments for diabetes that can keep people healthier. So people often ask me, is Friedreich ataxia related diabetes type 1 diabetes or type 2 diabetes? And you know, anyone who cares to, I could talk about this for hours with you, and enjoy it. But the main thing to tell you is that Friedreich's related diabetes is Friedreich's related diabetes. It has some features shared with type 1. It has some features shared with type 2, and different individuals are different. So labeling a type of diabetes is sometimes helpful when it guides our care. It's not helpful when people stop thinking. So these days, I say to educate people, like Friedreich diabetes is its own kind of diabetes. So then people taking care of you have to get curious and be like, well, what's true of your Friedreich's related diabetes, and how does that influence our treatment choices? So we know different prevalence estimates, around 10% of individuals will have diabetes. Many, many more will have pre-diabetes or will have features of high blood sugar when they're sick or stressed that require treatment. The same risk factors for more severe FA kind of get recapitulated in who develops diabetes, also with older and more advancing age. And one thing I wonder, this has been true in other chronic health conditions that have risk for diabetes, conditions like childhood cancer, like cystic fibrosis. The more and more efficacious treatments that are developed that keep people alive and healthier longer, which are amazing, sometimes people then live longer and develop diabetes. So this is something that we're paying more attention to as we go. With respect to management, we really want to stay on top of blood sugar so that people stay healthier and can stay out of the hospital as much as possible. For many people, especially for children, insulin production is not enough, so insulin needs to be the right choice. More people, including adults who develop diabetes related to Friedreich ataxia, end up needing insulin than would be true for so-called common type 2 diabetes. So insulin is appropriate, especially for children, especially for people who have shown up with diabetic ketoacidosis, which is one serious complication of diabetes, or who have a lot of weight loss, a lot of dehydration. Insulin's often the right choice. However, other classes of medicines can be really helpful. We were asked more about this last year, so I'm mentioning a couple of classes just so you're aware of them, especially if you have early diabetes, people may consider treating it. I think that's not wrong to do. So everybody's heard of Ozempic and Mounjaro and that class of medicine because they cause weight loss. So for people who do have excess weight gain and for whom weight loss is a goal, these medicines actually can be really helpful at achieving diabetes management and helping with weight loss. There's no free lunch though, like these do have side effects. And one of which we're becoming aware of, especially in this class of medicine, is that the weight that is lost is not all fat. We wish we could target it to only that, but people tend to lose quite a lot of muscle as well, especially folks who are not walking around or moving as much. So if this is the choice of medicine, being very deliberate about how to maintain muscle mass during treatment is really important. SGLT2 inhibitors are medicines that were initially discovered and used for diabetes, found to be helpful for people with different kinds of heart failure and cardiomyopathy. So really exciting for people with Friedreich's who may have both diabetes and heart problems. The one serious side effect that they can produce is excess risk of diabetic ketoacidosis. That's particularly true for people whose pancreases are not that healthy and don't produce a lot of insulin, which is very true in Friedreich's. So we have our patients at CHOP who receive these medicines learn how to monitor ketones so they can stay on top of this particular side effect. So that is something I routinely recommend to anyone taking this medicine. So being screened every year, educated about symptoms, check, you got that. Fatigue, weight loss, excess urination, but really a change from your baseline, this should be on your list. Screened with hemoglobin A1C and fasting glucose. Dr. Lynch will see you in clinic, we'll recommend it, and we'll get it done. Hemoglobin A1C is a number you may have heard of. It gives us a sense of what average blood sugar has been over the past 3 months in red blood cells. Red blood cell turnover may not be as typical in Friedreich's, and A1C is an average over 3 months. So if someone's getting sick within the past 2 weeks, the hemoglobin A1C may be falsely reassuring. So if you have symptoms, A1C plus other testing is often reasonable. All right, so can diet and or exercise help my symptoms or progression of disease? So I think Kim already mentioned this. Exercise is expected, I'm aligned, but we're saying it again because it's so important. Expected to have many of the same benefits in people with FA in those without, especially if you can find a way to do it safely for you. Especially, to what she spoke about, but we talked about, Dave talked about mood, sleep, like incredibly important benefits there as well. Fatigue may mean that shorter bouts of exercise work better. So that when you talk about being creative, like that's one thing that we've recommended clinically. And we'll talk a little bit later about our research in this area. So Dave, you and I I'm gonna tag team with you on this, right? So like medications and supplements, what are recommended? I'm gonna switch over to Dave because I already spoke about vitamin D.
Thank you, Shayna. It says I have 10 minutes. I would have time for at least a question or two, so I'll talk fast. I was gonna talk fast anyway. I honestly, I give OMAV to anyone who's 16 or older. We're testing trying to find the dose in kids right now, and then it will go through a clinical trial at some point, which will tell us more about that. I know our friends from Biogen will probably talk about that. Vitamin D, not calcitriol. You can take too much vitamin D, and that is bad. It is one of the vitamins that we are taught the effects of hypervitaminosis D, which it's easy to get into with calcitriol. NAD precursors, you can flip a coin either way on this. Shayna's study will have data within the next 6 months, right, Shayna? Adebin or coenzyme Q, that is the only thing for people who are not taking anything down the road that I would make a specific recommendation, because the data from cell models is sufficiently good, and it certainly has no adverse events and is not too expensive. There may be others. There simply is no data. I would say that almost all supplements are pea shooters compared to prescription medications. They may produce more benefit, but we probably will not see studies showing that they do. And they are medications and they can interact, which allows me to go to my next slide, which is to talk a little bit about OMAV, because it is not an official Friedreich ataxia talk unless we talk about OMAV. It's 1 year later. I can keep this pretty simple. Read the clinical trial. Prescriptions of the 300 people I prescribed for look a lot like the clinical trial. Most people get better. A few people notice actively no difference. Some people don't seem to respond at all. So a good drug, and some people a very good drug, but not a cure. The specific things we know 1 year later. All the stuff about transaminases and things, yes, you need to get them checked. Do it beforehand, but they haven't panned out to be anything more than lab markers. The one which we need to keep our eye on, maybe because it's something that I obsess about now, is cholesterol. Remember, hypercholesterolemia is not a problem over the course of a year or 2 years. A problem over the course of a lifetime, because it does lead to coronary artery disease. So OMAV does raise cholesterol in some people more than others. So that's the one you need to follow. And if it gets, LDL gets high, consider treatment. The other thing to talk to your doctor about is what other medicines you're on and drug interactions. Everyone seems to remember the calcium channel interactions, which causes to change some doses. No more, you still get the same effect of OMAV. We just have to change the dose a little bit. People in general remember that don't take OMAV while you're on Paxlovid for COVID, because there's an interaction there. It's a brief one, so you don't really have to worry too much about it. People don't remember that there is a probable interaction with CBD, the non-hallucinogenic component of marijuana, which is not very much talked about. And really, since that's sort of dosed in a funny way, hard to characterize, we're still sort of making up the rules on how you change doses of those. But there is one that people commonly forget about: oral contraceptives. That is, the official line is that oral contraceptives may not work as well if you're taking OMAP. So think about what that means and what you want to do. And please talk to your doctor about how to deal with this, because there are lots of possibilities. In this case, if you're taking oral contraceptives as contraceptives, then you're going to need to double cover things to prevent pregnancy. If you're taking oral contraceptives purely for menstrual cycle regulation, then you'll know whether it works or not, and then talk about with your physician whether you need to change the doses, whether you need to move to a new paradigm for menstrual cycle regulation or not. But don't minimize these things. It is a real drug interaction that you need to bring up, and I think people forget to talk about it. So that's OMAP a year later. It says we have 5 minutes and 35 seconds. We can take questions from the audience. Anyone out there? That was not a question. Alice.
Over here.
Yeah, I think your microphone will be on.
Is my,
Yeah, it's on.
oh, good. Well, thank you for that question. I appreciate it. I'll say a couple things. One is your question is the perfect preview for the next session, where we're going to talk about the ongoing, almost done, as Dave said, NAD precursor plus exercise study. So thanks to the community and to the National Institutes of Health, we should have more human data from randomized trials shortly. Yeah. On one form of NAD precursor. So that's one point. Secondly, there's some really promising preclinical studies, so studies in animals about NAD precursors and the improving survival or cardiac health in animal models. Animal models are not people, we know. So I think the studies in people will be more informative. Also, there's lots of different ways to try to boost NAD. And so we don't know which ones will be most efficacious and safest. And finally, we don't even know if actually it's raising the NAD, that's the thing we want to do. There's been some studies at CHOP and Penn and elsewhere that suggest that NAD precursors may actually work by affecting antioxidant balance. So I think we have a lot more to learn in this space before we recommend it, particularly in its IV form. But to know that, especially as this study comes to an end and we see what we find, that we're actively pursuing next steps. Does that start to answer your question? Yeah, I think it sounds like a pretty individual question. So but the short answer is sometimes the animal models do get sick from NAD, and especially, it's analogous, I think, to what Dave mentioned for the iron. Like, you can deliver a lot of something IV. So, the downsides that you might not appreciate as much with an oral supplement, if you see it with an IV, it might be more severe. So,
and I would actually say that the most important thing about sharing this study, when you talk about giving an IV, is not whether it works or not, but the safety line and how safe it is, which I do not think is known.
I think that's
no harm.
That's a really great point, right? So people, and you asked the very same question, like, is there a downside? And the short answer is, if it hasn't been studied in FA, like, we don't know. And so then that's a significant risk to take potentially.
Okay. Other questions in back? Kara has someone there.
So you were saying that vitamin D, that there's a too high level. What is that? Or like for supplementing daily?
Yeah.
What is the over limit?
Yeah, so great question. So the levels are usually in the US measured in nanograms per ml, and the reference range will usually go between 20 or 30 and 100. We say, you probably don't need levels above 50 to 60 to get benefits. And if you do see levels that are too high, you can get high calcium levels, which is also not good. High calcium levels can make you feel gross, can cause kidney stones, can potentially make heart rhythm problems worse. So that's not the direction you want to go. Your question may be like, well, how many units a day is too much? And that really depends. Different people require different amounts, especially folks with chronic health problems. So that's why if you do have a chronic health condition or choosing to take vitamin D, our practice is to check what people's levels are on their supplementation regimen, just so we can see and make sure they're in that reasonable range. Does that answer your question?
If I remember correctly, though, you can see hypervitaminosis D at 5 times RDA supplementation or some number
Yeah,
like
it's
that.
not that hard to
It's
do.
not that hard to do. It's so possible that they actually teach it in medical school.
And I think where Dave is coming from is it's unlike some of so vitamin D is fat soluble, so it sticks around for a while, and it's not just, you don't just pee it out the way you might some other vitamins. So it is worth being thoughtful about how much is given.
We have 3 seconds.
Dr. Lynch, in your experience, have you seen patients with normal vision and hearing, but differences in auditory and visual processing?
Yes. So, actually the question is, the answer is no, because in fact, vision is always subclinically affected in FA, and probably auditory function is, but it's not your standard audiogram. That said, there are people who have no obvious clinical phenomenon, who have processing difficulties. That's probably not directly related to FA. It's probably related to coexistence of visual and auditory processing disorder from other reasons. I will take one more, and then they're going to throw me off the stage. Yes. Yeah. So, I mean, there's probably no harm, but above OMAV, there'd be reason to believe there isn't necessarily any benefit. That said, there is the possibility that, for example, there's a paper published at the University of Maryland several years ago that says adibinone is a prodrug that needs a reduced environment to be converted to the active form. Who would have reviewed that paper? Oh, shooters me. And it was accepted, and that would make a rationale that they may be more effective in the presence of OMAV. Interesting experiment. I believe someone's trying to do it. So, but no proof, but no disproof.
I have a quick question since you're all doctors. So it's kind of a two-parter, real quick. So part of the problem that we have with Sean, because he's an adult and he's not light, and he uses a wheelchair full time, is getting, when you're talking about growth, and I know it's more important in kids, but we can't get a weight on him because even at CHOP, they don't have anything to weigh him. We know how much the wheelchair weighs. And our hospital, our local hospital, is a really big medical center, and they don't have it either. I mean, how do we go about doing that? I mean, it's pretty much at this point, it's estimates.
Do you know, CHOP does have some wheelchair scales. So I don't know if Dave, I know where it is on the 7th floor. We have one. So if you do know how much the wheelchair weighs, we do have wheelchair scales on. I believe we have one on each floor, but Dave and Kim can speak to what they have in their units, where you can, like, if you know the weight of the wheelchair,
I'll
like,
let Kim
wheel
speak
the
to that
person on, to get that, because that to my mind is the safest way to do it. And that's a reasonable weight because the wheelchair weight is pretty established.
I think you're pointing out, and Dr. McCormick has already pointed out, a perennial problem, right? And we need to do better. We have a wheelchair scale in the cardiology clinic at CHOP, and our MAs don't always know how to use it. The doctors don't also always know how to use it. And I think that some of these scales are only rated up to a certain weight that may not take into account the bigger power chairs. So we're often sending our patients to the 7th floor for the the wheelchair scale in neurology. So yeah, we need to do better, like all around, asking for it, getting it done, training ourselves. Yes.
So, and tying into this really quick is, so Sean's going to have his echo this month. And then he's been having really bad back pain and it's been going on a while. And now that you talk about maybe compression fractures, I'm thinking, well, maybe he needs to have a bone density scan. Transferring him for an echo or a bone scan is like the two of us. I mean, and again, major hospital, two of us and the technician trying. I mean, they don't have lifts. I mean, how do you work around that?
Well, Dave, you look like you had a comment first, but then I have.
Well, we have a very limited number of Hoyer lifts in the Children's Hospital of Philadelphia. I'll leave it right there.
Yeah.
Unless someone from the Children's Hospital of Philadelphia be spying on this.
So we do have some Hoyer lifts and not enough, but the 2 points I would make is that we do have the wheelchair scale, and our team, and I know some folks from our research group have undergone a training that the hospital does offer each year to staff to help work with folks with mobility limitations. We do have some of our patients who contact us ahead of visits. They shouldn't have to, but to remind us to say, hey, gee, this is an issue and this is a challenge for us. And so we do have, that I have the nurse who leads that initiative on speed dial to like ask for her help if we have someone coming in who's had especially someone who's had a not great experience in the past, to say, hey, what can we plan ahead of time to see if we can do this more safely, more comfortably for this person.
Just to add to that, I think in peds cardiology, like we're behind in terms of equipping ourselves to do adequate testing as standard of care in a good number of patients like Sean and like others. Just a couple small points. Our sonographers are learning to be more flexible in terms of allowing someone to stay in their chair if it's actually better in their chair than on our table, meaning neither is going to be perfect, but some folks have a chair that can recline enough and someone can get to a comfortable enough position that maybe that's even better than the full move to the table. That's not always the case. It's sort of risk and benefit. And the other thing is, if someone has very difficult echo windows, one of the newer techniques that we've been using more is arranging advance for being able to give a contrast called Lumison to be able to visualize the heart chamber relative to the heart wall during an echo, especially if it's a pattern. Like every time we're complaining, oh, we can't see very well, we can at least outline the chamber better with something called Lumison. That's available at a lot of adult institutions also, but you do have to plan in advance for that. So.
Yeah. Okay. Good. Thank you all very much.
Thanks, everyone.
Oh, that's right. Let's take it.
All right. Well, if I could have the next panel come up, this is pipeline panel 1. And can I get the slides for that? While the panelists are coming up and we're getting the next session started, we want to do a little bit of polling from the audience. And so you will see QR codes on your tables. There's also instructions here on the screen. We're going to practice with a few simple questions, but we're going to use more polling in the afternoon during the digital device session. So the first question that we want you to answer is, how many times have you attended this symposium? Again, you can just get the QR code off of the little table tent, and that will take you to the polling link. Oh, good. People are picking it up. That's great. Most of the people who figured out the polling are new time attendees. That's awesome. We've got a good mix in the crowd of new folks and folks who've joined us in the past. All right, can we try the next question? All right, where did you travel from? So this question, we want you to just write something in. Where did you come from? Oh, this is fun. Montana, Boston, Pittsburgh, Switzerland. All right. New Jersey, Connecticut. Oh, this is fun. I love the word cloud. All right. Super cool. All right, next question. The next type of polling question we're going to use allows you to select multiple answers. So how have you been involved in FA community? And answer all that apply for you. Are you involved in advocacy, fundraising, ambassador program, research studies? Are you still trying to figure out what your role is? Awesome. So it looks like at least 90% of people have been involved in some way in the community. And I hope that today, the 10% of you who are still trying to figure it out, find your activity, find your role. So thanks for helping us test out the polling. And we're going to be using that a little later in the day. And now we'll be able to move on to our next session.